The next lecture is by Dr. Dinuka Sanathani Varapitiya, Senior Registrar in Nephrology, National Hospital, Kandy. It is evaluation and management of acute kidney injury in patients with cirrhosis. Dr. Varapitiya.
Thank you for the kind introduction, sir. So I'll tell. I'm going to talk about the acute kidney injury in a cirrhotic patient. So in my lecture, I'm going to discuss about the evaluation of the acute kidney injury in a patient with cirrhosis. And also I will tell about the initial management steps in managing AKI in cirrhosis. And also here I will tell about the hepatorenal syndrome and its management. So as you all know, in cirrhotic patient, they can develop AKI as inward patient as well as outpatients. So if they develop AKI, it will increase their morbidity and the mortality by 7-fold. That what has shown in the research. And if they get repeated episode of AKI, that is a risk factor to develop chronic kidney disease. So this is a case, I will read it out. A 56-year-old man with end-stage liver disease, secondary to non-alcoholic due to hepatitis, developed acute kidney injury with an increase in serum creatinine from a baseline of 1.2 milligram per deciliter to 3.1 milligram per deciliter following an outpatient large volume paracentesis, which was performed for recurrent ascites. His blood pressure is 98 by 54 millimeter mercury with a heart rate of 86 beats per minute when supine, and he complains of lightheadedness upon sitting. On examination, he has minimal ascites and no peripheral edema. His urine sediment is black, and so my question is, what would be the etiologies for his AKI? So there are AKI, cirrhotic patient can develop AKI due to many reasons. The most common reason is pre-renal processes like hypovolemia and also hepatorenal syndrome, and they can also develop AKI due to intrinsic renal diseases like acute tubular necrosis, interstitial nephritis, and the glomerulonephritis. So glomerulonephritis mainly common, the cirrhotic patient, they can develop because of secondary IgA nephropathy, and if they develop cirrhosis because of hepatitis C, they are at a risk of getting the glomerulonephritis due to cryoglobulinemia and the proliferative glomerulonephritis. And if they develop cirrhosis because of hepatitis B infection, so they can develop glomerulonephritis due to membranous nephropathy. And also they can get AKI due to obstructive uropathy, the post-renal causes. So before telling about the evaluation of AKI, I will tell about what happened to serum creatinine and the glomerular filtration rate in a cirrhotic patient. So as you all know, in cirrhotic patient, their production of creatine is less and they can have protein calorie malnutrition and the muscle wasting. So therefore, if you use serum creatinine and calculate the estimated glomerular filtration rate using a formula, it will overestimate the patient's true glomerular filtration rate. This commonly happens if their true GFR is less than 40 milliliter per minute per 1.73 square meter. So they say it will overestimate by 10 to 20 milliliter per minute per 1.73 square meter of body surface area. So, and other thing, if they have hyperbilirubinemia, if we use calorimetric method to measure the serum creatinine, that value is not accurate. And also if they have fluid overload, although they have low GFR due to AKI, it takes some time to show high serum creatinine. So the other common measure that we talk about, fractional excretion of sodium, and how do we use this to differentiate hepatorenal syndrome, AKI, and the acute tubular necrosis. So hepatorenal syndrome and pre-renal AKI, their urinary sodium is less than 10. But if the patient is on diuretic, that we can't use that value. Another thing, in acute tubular necrosis, the urinary sodium is more than 10. And if we take fractional excretion of sodium, so that is usually less than 1% in pre-renal AKI and more than 1% in acute tubular necrosis. But in cirrhotic patients, they have a tendency to retain sodium. So even without AKI, their fractional excretion of sodium is less than 1%. So when these cirrhotic patients develop hepatorenal syndrome AKI, so their fractional excretion of sodium will be less than 0.1%. So this is very, very low. So the recommendation is now not to use fractional excretion of sodium alone to differentiate HRS-AKI from the acute tubular necrosis. So the other thing is fractional excretion of urea. So it is usually less than 35% in pre-renal AKI and more than 35% in acute tubular necrosis. And it is less than 21% in hepatorenal syndrome. So this urea is reabsorbed in the proximal renal tubule and the collecting duct, and there is not much effect from the diuretics. And so now the recommendation is, if you combine this both fractional excretion of sodium, that is less than 0.1%, and the fractional excretion of urea less than 21%, with the urinary albumin excretion, that is usually less than 44 milligram per deciliter in hepatorenal syndrome, you can use these three values to differentiate HRS-AKI from the acute tubular necrosis. And we have other biomarkers like neutrophil gelatinase associated lipocalin, the NGAL, that is a mark of the tubular injury, that is high in ATN, that also can be used to differentiate HRS-AKI from the ATN, but their availability and their standardization, there's less evident, and there's a cutoff, there's uncertainty also regarding its cutoff values. So nowadays we're talking about the AKI quality improvement. So here we plan to actually prevent the AKI development in the inward patients, as well as we plan to prevent the complication once they complication of the AKI once they develop the AKI. So as a step to improve this AKI management, some have introduced care bundle for AKI management. So in summary, here we should diagnose the AKI, that is by using the KDIGO criteria. So in KDIGO, to diagnose AKI, there should be rising creatinine more than 0.3 milligram per deciliter within 48 hours, or rising creatinine more than 1.5 times within 7 days. And also the urine output should be less than 0.5 milliliter per kg power for more than 6 hours. So you have to diagnose the AKI and then see and find out the etiologies of the AKI by doing the investigations. You have to see whether they are a pre-renal or intrinsic or post-renal AKI, and assess the patient's fluid status, and then assess the patient's complication of the AKI. So any patient who has fever, diarrhea, and AKI, we have to omit these drugs, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, non-steroidal anti-inflammatory drugs, diuretics, metformin, as well as nowadays SGLT2 inhibitors. We have to omit. Those drugs can worsen the AKI. And this is a workup plan. How do we approach the patient who has AKI? The patient with cirrhosis who has AKI. So the first thing is you have to diagnose there is AKI by using the KDIGO criteria, and then the history and examination. Here we have to try to see what are the risk factors this patient has which can contribute to development of AKI. Whether this patient has fever, diarrhea, whether this patient is on nephrotoxins like NSAIDs, whether patient has taken excessive diuretics. The target is less than 500 gram per day weight loss. That's how we should prescribe diuretic. But if this patient is on excessive diuretics causing dehydration or excessive doses of lactulose, the target is 2 to 3 bowel opening per day. And then whether this patient has recent undergone any contrast studies. So then we should do an investigation. We have to do a UFR to see whether there are any active sediment to exclude glomerulonephritis, and the renal imaging to exclude any obstructive uropathy. And especially we have to assess the fluid status of the patient. And if the patient is dehydrated, you have to hydrate the patient using a crystalloid. And even if this cirrhotic patient is euvolemic, the recommendation is achieve a fluid volume expansion by using a 25% albumin, the 1 gram per kg dose. The maximum dose is less than 100 gram per day in divided doses. Then you have to repeat the creatinine in 24 hours. So if the creatinine is reducing, then you can continue monitoring for renal recovery. But if the creatinine is unchanged or it is rising, then again you have to reassess the volume status and hydrate the patient well, and also give albumin, the 1 gram per kg dose, and then repeat the creatinine in 24 hours. So if the creatinine is dropping, then we can continue monitoring for renal recovery. But if it is not reducing, then we have to think of intrinsic AKI, whether it can be ATA or HRS AKI. I'll tell about what is this hepatorenal syndrome AKI. So hepatorenal syndrome, it's been defined as a renal dysfunction that occurs because of reduced renal perfusion due to hemodynamic alteration in arterial circulation, as well as overactivity of the endogenous vasoactive substances. So this is the behavior of the cirrhotic patient. Initially, they have diuretic responsive ascites with normal or near normal GFR, and then they get diuretic refractory ascites with reduced GFR. And when they develop hepatorenal syndrome, they have very markedly reduced GFR. So this is a you can see, so in cirrhosis with ascites, so they have high tenders for bacterial translocation, and because they have intrahepatic resistant as well, and if they develop gastrointestinal bleeding, that also increase bacterial translocation. So this will increase pro-inflammatory cytokines in that patient's body. Not only that, if they develop sepsis and the spontaneous bacterial peritonitis, that also increase the pro-inflammatory cytokine. The spontaneous bacterial peritonitis is common reason that the cirrhotic patient develop AKI. So then these can cause splanchnic and the systemic vasodilatation. And if this patient undergo large volume paracentesis, or if this patient is on vasodilators, that also can cause splanchnic and the systemic vasodilatation. So this will reduce the effective arterial blood volume. So this will cause activation of neurohumoral systems such as renin, angiotensin aldosterone system, sympathetic nervous system, and the arginine vasopressin system. And it results in renal vasoconstriction and then it reduces renal blood flow, and you will get the HRS AKI. Not only that, because splanchnic and systemic vasodilatation, it can increase cardiac output. So later the patient develops cirrhotic cardiomyopathy, and it reduces finally the cardiac output, and you have a reduced renal blood flow, and you get HRS AKI. So in HRS AKI, although there is systemic vasodilatation, in kidney, inside the kidney, there is intrinsic renal vasoconstriction. So this now I'll tell what is this HRS AKI, HRS non-AKI. So initial classification was HRS type 1, that is acute form, and HRS type 2. So HRS type 1 is was defined as doubling of serum creatinine to a level of more than 2.5 milligram per deciliter, or a reduction in creatinine clearance by 50% or more to value of less than 20 milliliter per minute over a duration of less than 2 weeks. The type 2 is moderate and stable reduction in renal function. So type 1 HRS has more mortality when compared to type, if you see the survival curve, so type 1 has a more mortality when you compare with the type 2 HRS. So now the newer classification is HRS AKI and the HRS non-AKI. So HRS AKI similar to a type 1 HRS. So here you should have AKI according to the AKI criteria should be fulfilled. So it's a KDIGO criteria we use now. Earlier the type 1 classification, it's not the KDIGO criteria, but now we use KDIGO criteria. So in HRS AKI, The patient can have cirrhosis, acute liver failure, acute or chronic liver failure, and there should be AKI according to the KDIGO criteria. And then this patient should not on any diuretic, or if this patient is on diuretic, it should be should be stopped for two days, and should have adequate volume expansion with albumin and fluid for about 2 days. And this patient should not be in the shock and not on any nephrotoxins. And there should be any renal parenchymal, evidence of renal parenchymal disease, such as proteinuria more than 500 milligram per day, microhematuria, that is more than 50 red blood cell per high power field, or other urinary biomarkers, and the abnormal renal ultrasonography. So if this criteria are fulfilled, then we say it is HRS AKI. Then HRS non-AKI, it is a more chronic form, so we can further divide it into HRS acute kidney disease and HRS chronic kidney disease. In HRS acute kidney disease, it's eGFR less than 60, less than 3 months in the absence of other creatinine less than 50% using the last available outpatient serum creatinine within 3 months as baseline. HRS CKD is eGFR less than 3 months for more than 3 months, eGFR less than 60 for more than 3 months in the absence of other causes. How do we prevent the development of AKI in cirrhotic patients? So the guideline suggests to avoid nephrotoxins in a cirrhotic patient like NSAIDs, and avoid prescribing excessive unmonitored diuretics, laxatives, and also they recommend to give albumin 4 to 6 grams following a large volume paracentesis as a method to prevent the development of AKI, and avoid excessive alcohol intake, and also prescribing antibiotic when there is episode of gastrointestinal bleeding, and antibiotic prophylaxis against spontaneous bacterial peritonitis also a method to prevent development of AKI in these patients, and also prescribe albumin during spontaneous bacterial peritonitis also a method to prevent AKI. But this doesn't mean that albumin can prevent AKI development in other infections. This only shown that albumin can prevent AKI development in spontaneous bacterial peritonitis. So how do we treat the hepatorenal syndrome? So the definitive management is liver transplantation. So nowadays, if this patient eGFR is less than 20, we can consider liver, kidney, both we can transplant. And then the other key management is vasoconstrictors with albumin. So we have terlipressin, norepinephrine, and midodrine octreotide. The midodrine octreotide has less efficacy. And then the transjugular intrahepatic portosystemic shunting. Now the recommendation is not to use tips, only to treat hepatorenal syndrome. And then the renal replacement therapy. So the place of the renal replacement therapy, we can use it as bridge therapy. So I'll tell about the renal replacement therapy. So this is a survival curve of the patient who has AKI. They have seen according to different etiologies what is a survival. So you can see patient who develop AKI due to HRS has more mortality. So survival is less. So therefore they recommend to prescribe dialysis or renal replacement therapy for the patient who has AKI due to HRS and who is awaiting for a liver transplantation. Because if you prescribe the renal replacement therapy, that is a costly treatment. So for the patient who has AKI due to HRS and who is not awaiting for a liver transplantation, so it's controversial because there anyway mortality is high. So this is another research. Here they compare the two patients there's two patients. The one patient, first group, they had AKI due to hepatorenal syndrome and received dialysis, and the second group they had AKI due to ATN, the cirrhotic patients, they all are cirrhotic patients, and they received dialysis. So then they compare their mortality. The two groups have similar mortality. So therefore, the some suggested to prescribe renal replacement therapy when there is life and acidosis. So in summary, so if you're prescribing renal replacement therapy, it should be individualized for patient who has AKI, individualized for cirrhotic patient who has AKI due to HRS. For example, like we can prescribe dialysis for cirrhotic patient who has AKI due to HRS and awaiting for liver transplantation, or who has life-threatening complication. So this is so here you can see this American guidelines. So for the next management is you have to use vasoconstrictors with albumin to treat hepatorenal syndrome. Now this is a confirmed trial. So here they have compared the terlipressin plus albumin treatment with the placebo group. This was done when there was a old classification there, and you can see the terlipressin plus albumin group can reverse the HRS when it's effectively than placebo group, and even their need for renal replacement therapy also less. But however, these patients who receive the terlipressin and albumin, the less number of patients has gone for liver transplantation. The reason is we use MEL score to decide which patient need liver transplantation, and the creatinine is one of the criteria. So once you treat the HRA, so the creatinine is dropping, so their MEL score is improving, so they will no longer be in a level that who need the liver transplantation. But nowadays they say that although their MEL score is improving after treating HRAs, they should give priority to give a liver transplantation. And the patient who received terlipressin plus albumin got more death when compared to placebo group. That is because of fluid overload and respiratory insufficiency. So if we see the survival in up to 90 days and transplant-free survival up to 90 days, both the placebo and the terlipressin group has similar survival. So the mortality benefit of terlipressin plus albumin group is uncertain, although it can reverse the HRS. So this is a meta-analysis of terlipressin in HRS. So you can see the terlipressin can reverse the HRS. And this is a requirement of dialysis. It can reduce the requirement, but the survival benefit is we can't comment much that terlipressin has a survival benefit. It's uncertain. So this is a meta-analysis of terlipressin versus norepinephrine for reversal of HRA. So both group has a similar efficacy in reversing the hepatorenal syndrome. But the adverse effect is more common in terlipressin group. The reason is the terlipressin causes pulmonary vasodilatation, whereas norepinephrine causes pulmonary vasoconstriction. So you get more pulmonary edema and respiratory insufficiency if you receive terlipressin. So when treating the HRS AKI, so as I mentioned, first you have to make a diagnosis of HRS AKI according to the criteria I mentioned, and then you have to administer vasoconstrictor plus albumin. Here the albumin dose is 20 to 25 grams per day, and then terlipressin you can prescribe 1 milligram intravenously every 6 hours as boluses. Norepinephrine you can prescribe 0.5 to 3 milligram per hour as a continuous IV infusion, and then the target is you try to achieve a increase the mean arterial pressure by 10 millimeter mercury. Then you have to repeat the creatinine in 72 hours. So if there is no, if the serum creatinine is still more than the baseline, then you have to discontinue the vasoconstrictor. Or if the patient develops complication due to vasoconstrictors, again you have to discontinue the vasoconstrictor. The complication like ischemic complication, respiratory failure, and the volume overload. Another thing, terlipressin, you can't prescribe the terlipressin for the patient whose oxygen saturation is less than 90 and who's having a grade 3 acute liver failure, as well as whose bilirubin needs more than 5 milligram per deciliter. But if the creatinine is reducing, then you can titrate the terlipressin dose. So according to the FDA, they say if the creatinine level decreased by less than 30% from baseline, then you can increase the terlipressin dose to 2 milligram intravenously every 6 hours. And the maximum duration you can give vasoconstrict is 14 days, and the maximum terlipressin dose is 12 milligram per day. To say there's a HRSAK reversal, you should have a 2 creatinine 2 hours apart. It should be less than 1.5 milligram per deciliter. So in summary, I talked about the how do we evaluate the AKI in cirrhotic patient, and I talked about the hepatorenal syndrome, its classification and the management. So in summary, there are multiple etiologies of AKI in cirrhosis, and vasoconstrictor therapy combined with volume expansion with albumin is associated with reversal of HRS, but the mortality benefit is uncertain. And the definitive treatment of HRS is liver transplantation. These are my references. So thank you.
Thank you. Hi. We have police. Development HRS in acute liver failure. Occasionally development of anxiety in activating the RAS system. So most of the patients who have acute liver failure do not have anxiety. So if the pathophysiology is different, two patients have anxiety that activates the immune system. That is my question number one.
In the acute liver failure also, there is an intrinsic renal vasoconstriction. So the pro-inflammatory cytokines is high. So that also can contribute to splanchnic and systemic vasodilatation. So they didn't in literature, I couldn't encounter any literature that it said there's a mechanism is different in acute liver failures, I think.
Second one is patients who with cirrhosis or chronic liver failure who has acute kidney injury, who is probably HRS, and mentioned requirement for renal replacement, because the physician now when they go into AKI, they will ask for a renal replacement therapy. They anyway their mortality is high, so giving high cost renal replacement therapy is of no benefit. I hope that it's the same for patients who requested for ICUs, renal, and we put them on CRRT. I think the answer will be the same, isn't it?
Yes, because the patient who is waiting for a liver transplantation, we can justify that prescribing the dialysis, either intermittent hemodialysis or CRRT. But if the other patient was not waiting for a liver transplantation, we have to think all the aspects and then decide.
The question you should ask is this patient, can this patient be a liver?
Yes, that's the other thing.
Okay.
The choice of vasoconstrictor in to chance. So I think we use both terlipressin and norepinephrine. But I think there's a huge difference in cost. So according to your data, is it advised to use maybe not doing more than terlipressin, because there doesn't seem to be any major advantage of one or the other? In fact, I think on what we showed, side effects are listed not different. So is it in a guideline?
So guidelines doesn't tell not to use terlipressin, sir. Because guidelines talk about the both drugs, the terlipressin and norepinephrine, and the terlipressin was recently approved by the FDA. It was not actually used in USA. It was recently started to be used terlipressin. So guideline doesn't tell that use norepinephrine more than the terlipressin because it has less side effect. But in literature, they show that there's meta-analysis. So it shows that the patient who received terlipressin developed more respiratory insufficiency because it causes pulmonary vasodilatation, and they have a high tendency to develop pulmonary edema.
Thank you.